Okay, well, thank you very much. As we mentioned before, part of the practical training will consist of case presentations. These case presentations will be done by us, similar to the one I'm going to do in a minute, but also you will provide them. So you will, as the training, as the master's program goes on, you will be asked to present a case of your own, if you have any, and discuss it in public, and you will learn with us aspects of treatment, diagnosis, etc. Okay, on today's case, what I want there are two messages that I would like to get across. One of them is the one that we mentioned already. Sleep medicine is an multidisciplinary area. At times you feel a pulmonologist, at times you feel an internist, at times you feel a neurologist, sometimes you feel a psychiatrist, and many, many times you feel a psychologist. You feel like a psychologist. You become practicing sleep medicine on a given afternoon. You go across all these specialties throughout the night. Sometimes you feel like a dentist, like a sleep dentist. I mean, it's really, you will be able to talk to people from very, very different backgrounds that have something in common with you, which is the interest in sleep medicine. The other thing I would like to get across with this case is the following. Even while you practice your specialty, you might make use of sleep medicine, and that will enrich your practice of medicine immensely, significantly. In the case I'm going to present, you will do that, exactly that, with, it's for a case of a patient with cognitive dysfunction. So it would be something, let's say, for a psychiatrist, or, well, depends on what country, normally for a neurologist, neurology, psychiatry, and how you might enrich your handling of the patient by understanding sleep medicine. Okay, so I called it on a case of memory loss and poor sleep, why we need to look into sleep. Okay, it's a case that we saw in our clinic recently, not that long ago. It's a male, 59 years old, that came to the clinic, and the complaint was poor sleep and insufficient memory loss. The patient had always snored, and before coming to us, the patient had been diagnosed like 5 years before from sleep apnea. He had undergone a sleep study years before, and I never saw the report. But in that sleep study, he told me the number of apneas was approximately 50 per hour. So they decided that 50 per hour is normally severe sleep apnea. Anything that goes beyond 30, adding together apneas and hypopneas per hour of sleep, anything beyond 30 is considered severe. So 50 is very severe. And accordingly, he had been prescribed CPAP at a pressure of 8 centimeters of water pressure. However, there was a very poor compliance. The patient wouldn't use it for even 3 hours a night at the beginning, at best. Later on, the patient decided not to use it at all anymore. As a result of that, the patient was sleepy during the day with an Epworth sleepiness score, which is a rating scale that measures the subjective degree of sleepiness. And he scored 15 out of 24 points. 24 would be the absolute maximum in terms of sleepiness. 15 is already pathological, but it's like I would call it moderately pathological. The patient had also been pre-diagnosed for restless legs syndrome. He would move a lot at night, but a previous neurologist had diagnosed the patient for restless leg syndrome. Bed routines were the following, more or less. He would go to bed at 12:30, well after midnight, to 1 a.m. Why to bother going before that? Because probably he wouldn't fall asleep. So it was nothing he chose, but it was something there was no other option. He would fall asleep quite quickly at the time already, in less than 10 minutes. But approximately half an hour later, he would start waking up, and the entire structure of the night was falling asleep, getting up. It was a very fragmented sleep with lots of sleep interruptions until he got up at 7 in the morning, and he would have an average subjective total sleep time of less than 3 hours. That's what he told us. Okay. Sorry, I'm having some technical. Okay. The past medical history. The patient was obese with a BMI of 32.7. You can see just below, the patient was 98 kilograms. That's like almost 200 pounds. 98 kilograms heavy, and he was 173 centimeters tall. As a result of the obesity, the patient had undergone a gastric bypass in 2005. So before that, he was even more obese than that. He suffered from arterial hypertension, diabetes mellitus type 2, dyslipidemia, was suffering from ischemic heart disease with a myocardial infarct, and had been placed, according to his statement, 5 different stents. 5 stents had been inserted. He also suffered from intestinal diverticulosis. He had been a smoker. A heavy smoker until 5 years before, probably until the first myocardial infarction. The medical and neurological evaluation, particularly the neurological evaluation, didn't show very much. But if you look here, there are 5 different risk factors, cardiovascular risk factors. The first one is the obesity. The second one is the hypertension. The third one is the diabetes. The fourth one, the dyslipidemia, and also the previous presence of ischemic heart disease. All these, and also the smoking. So he had all the different tickets to have a severe cardiovascular disease. That's what we knew at that point. Okay, then we ran several questionnaires, the insomnia severity index, where he ranked quite high. He scored quite high with a 24 out of 28, so that's severe insomnia. Although, despite the fact that he was, as we will see in the next slide, under hypnotic medication. On the Hamilton rating scale for depression, he's ranked at 11 out of 52, which means mild depression, very mild depression. It's not completely normal, but it's not a severe depression. As I mentioned before, the Epworth Sleepiness Scale, 15 out of 24, which means mild, moderate daytime sleepiness, which is a little bit surprising given the few hours he slept and the severity of the sleep apnea, but that was his subjective opinion. And we also run the International Restless Leg Study Group scale, where he showed a 31 out of 40, that means severe RLS. Okay, treatments. He was currently being treated with pramipexole, a dopamine agonist, at a relatively high dose, 1.5 milligrams per day. For a patient with restless legs, that's quite a lot. In addition, he was also being treated with clonazepam, benzodiazepine. That's the hypnotic I was referring before to. He was also being treated with amlodipine for the heart condition, also for the hypertension, hydrochlorothiazide, bedagliptin for the diabetes, liraglutide for the injections, also for the diabetes and the obesity, pitavastatin for the dyslipidemia, ezetimibe for the dyslipidemia as well, and also acetyl salicylic acid. For the RLS, before the pramipexole, he had been treated with high doses of both ropinirole and rotigotine, the other two dopamine agonists. Well, what we knew about the RLS, he was having a discomfort in the legs, in the lower part of the legs, but and they started distally and bilaterally, but later on, and the drugs and initially the ropinirole helped him a lot, but later on not so much anymore. And with the course of time, these initially distal symptoms became more proximal. They never reached the level of affecting the arms or the trunk, but they reached the entire leg as a result of the ongoing treatment. He had been treated with ropinirole 0.5 to 1 milligrams initially, that he responded, but later on that was not sufficient any longer, so the dose had to be increased to 4 milligrams per day, which is the highest dose you can give, you can administer of ropinirole in an RLS patient. Symptoms had been getting worse over the years, more and more, so the dose had to be increased, and now we were at the limit because we were already treating him with the last of the dopamine agonists, pramipexole, with the highest doses possible. Lately, symptoms had been starting earlier in the afternoon when the patient relaxed. So initially, symptoms had been starting at the beginning of dinner time, 8, 9 p.m., but as a result of the worsening of the condition, now symptoms were starting already after lunch. We performed, we were not able to obtain the PSG, so we performed the PSG, and we'll show you all of that. But please, let me just, for the sake of time, go to the basic things. He slept not even 4 hours, 222 minutes. He slept 62% of the time that we gave him to sleep. He fell asleep very quickly in 1.5 minutes and stayed awake for almost 2 hours during the rest of the night. The sleep architecture was, I can say it in one sentence, a lot of superficial sleep, little deep sleep or REM sleep. So that's a typical marker of a very fragmented sleep. In addition to that, we found a number of periodic leg movements, which are leg jerks that are very typical of RLS. During the master's degree, you will hear a lot about them. So we count the PLM index both during sleep and while awake. The one during sleep was 23 leg jerks per hour of sleep. That's a lot. That's increased. But during wakefulness, in the periods of time that patients stayed awake during the night, he showed even more, 52 per hour. Regarding the respiratory, so we got almost 3.5 to 4 hours of sleep. And in that period of time, we found 56, adding together apneas and hypopneas and respiratory-related arousals of the EEG. You'll hear a lot about these concepts whenever we talk about sleep apnea. He came to 56 events per hour. These events occurred as frequently during while the patient was sleeping on the lateral decubitus as when the patient was sleeping in the supine position. So it was not a positional kind of apnea. Regarding the oxygen, the one awake was fine, 94%. The mean was a little bit low, 89%, and the lowest SaO2 during REM sleep was, during REM sleep it came back down to 66%, and during in the minimal value was 77 per night. The patient spent 71% of the night with suboptimal SaO2 values. So in one word, in one sentence, as I explain it to the patient, he was hypoxemic for a lot of time, but not very hypoxemic during that time. And the EKG was fine, was okay. We were wondering, since the Epworth Sleepiness Scale score is just a 15, whether, well, we performed a maintenance of wakefulness test. That's a test in which we ask the patient a number of times in the morning to stay for 40 minutes. We did it here, in this case, 3 times, 40 minutes. And we're in a dark room without any acoustic noise or any environmental factors that might arouse the patient. Eyes closed, EEG on, and we told the patient, try to stay awake. The normal thing, any of you, if I asked you to do that, at least the minimum you would stay awake would be, I would say, 19, 20 minutes. This patient on the first of the test stayed awake for 6 minutes, then 8. So he was having he was clearly somnolent. This was a pathological sleepiness. The mean was 7 minutes, 28 seconds. That's just to contrast with what the patient perceives. One thing is perception, the other thing is objectivity. And so we came to the conclusion, no positional sleep apnea, fragmented sleep with PLMs. In addition to that, we performed a multiple suggested immobilization test. Here the patient, that's something we do before the PSG. The patient is awake, as you can see, is half sitting in bed with the legs stretched out and separated. And what we tell the patient is try not to move, try not to move. And what we saw here is, okay, it's visually very interesting. So the patient is showing leg jerks throughout the night. Imagine with that to try to fall asleep. It would be just impossible. I mean, imagine you have that throughout the entire night. The other thing is that we also ask the patient on a visual analog scale every 10 minutes on 2 of the tests. We did this twice, to score between 0 and 10, being 10 the worst, and being 0 no symptoms, the severity of his symptoms. And you can see here it's a 1, 2, 3, 5. So as time goes on, symptoms get worse and worse and worse. And on the second test, more of the same, 0, 3, 4, 5, 5, 7. So you can see here that these leg jerks and these aesthesias, this disturbance is depending on the time of the day, because it gets worse in the second test compared to the first one. And immobility, trying to remain immobile, worsens them. Okay, we came to the conclusion that there had been a worsening under the dopaminergic medication. So the criteria for dopaminergic augmentation are, just to say it briefly, it's an earlier onset of symptoms in the afternoon. He had that. Shorter latency to symptoms at rest. Yes, always compared to before the treatment had been initiated. An overall increase in symptom intensity, that was the case. Longer latency until onset of therapeutic effects, that was also the case. An expansion to the arms, trunk, or abdomen. This was not the case here. But still, he met criteria for dopaminergic augmentation. So what does it mean in one sentence? The dopamine agonist initially alleviates symptoms, but later on, if you keep the treatment over a longer period of time, you will see that it does less and less and less with the course of time. And at some point, it will turn around and do exactly the opposite. From being a tool that improved symptoms, that alleviated symptoms, it turns to the contrary. it becomes a tool that exacerbates symptoms. And this is the nature of dopaminergic augmentation. He was suffering from that. It's very common in RLS patients that are being treated with high doses of dopaminergics. So it's a iatrogenic worsening with the drugs that you are giving the patient to help him. We looked also into the iron levels, and what we found there was that, I'll just summarize it for you, ferritin and transferrin saturation are okay. Everything is okay in serum iron. Everything is okay. However, ferritin and transferrin saturation are close to the lower margin of normality. Okay, we know by experience and by research that the main problem in these patients is not a peripheral iron deficiency. The main problem, what causes the RLS, is a brain iron deficiency. How can we see how iron is in the brain? Well, the easiest way, it's a technique that was developed a few years ago by Dr. García-Malo, sitting next to me, is by means of quantified transcranial sonography. It's something you can do easily as many times as you need because it's harmless for the patient. And what you do is you measure the echo-density of the substantia nigra. The substantia nigra is a structure in the brain that is the main iron store for iron. And what we do there is we measure the echo-density because it's assumed that the more iron there is, the higher the echo-density. We come to the so-called substantia nigra echo-density index, which is okay, which is it reflects the surface of the substantia nigra. The higher the echo-density, the higher the number will be. It's an indirect reflection of the content of brain iron in the substantia nigra, not in the brain, but in the substantia nigra. And the substantia nigra is the main iron store in the brain, so it's really the one that matters most. It was a 0.15. Is that high? Is that low? Well, normally you need at least 0.21, 0.22. It's low. It's definitely low here. So we can really say that the patient was having a brain iron deficiency. I'm having some problems with the marker passing the slides. And I might need some help because it takes a while to. Okay. So in other words, what we find here is that the patient has marginally low serum iron values, and it has definitely low brain iron values. And that might explain the emergence of the RLS. The patient also complained of cognitive problems. He would misplace things increasingly and used more frequently notes and reminders. He was 59, I remind you. The relatives reported questions needed to be repeated. Increasingly, patient did not keep track of appointments or dates. The patient needed to be reminded of names of close relatives and friends. Moderate difficulties to follow when reading. Okay, the typical question here is, to what degree is this age-related? You are getting older, yeah. That's a typical thing that everybody thinks at the very beginning. The question is, how sure are you that this doesn't go a little bit beyond your age? So we interviewed the patient with the mini-mental state examination. Neurologists and psychiatrists are very familiar with this tool. It can be done in 10 minutes. And it measures very quickly in quite a standard way orientation, registration. By the registration, I mean the capacity to memorize things, at least to memorize initially on the short-term things. Attentional calculation, recall, I mean the capacity to retrieve whatever you have memorized before a couple of minutes later, language, and pentagons. So it measures several cognitive functions. What we found here is that he scored the maximum in orientation to time and place, also in registration. He didn't score the maximum in attention and calculation, so here we get a little deficit in attention. He didn't score well at all in recall. He was not able to retrieve the information learned before, and he didn't score the highest on language. So he got a 26 out of 30, which is a little bit under what is expected for a normal person. Yeah. So these are the three areas of deficits. The diagnostic criteria for mild cognitive impairment are, first of all, a concern either by the patient, by a relative, or by a skilled clinician that there is a change in condition, a change to the worse. The objective evidence of impairment in cognitive testing, that could be one, the mini-mental scale could be one. In cognitive domains like memory, executive function, attention, language, visual-spatial skills. But while having that, the patient preserves independence in areas of daily living. It's a patient that can do everything by himself, doesn't need anything, just has a little bit of a cognitive deficit, just that. And the patient has no significant impairment in social or occupational functioning. It's not demented. So far, what are the diagnoses? First, by polysomnography, obstructive sleep apnea. That's definite. Severe obstructive sleep apnea. By polysomnography, but particularly by the a multiple suggested immobilization test, restless leg syndrome undergoing dopaminergic augmentation. Third, brain iron deficiency by transcranial sonography. And also by means of the neuropsychological testing. I'm not getting into, we did the MMSE, we also performed later on the Montreal Cognitive Assessment, it showed the same thing, and we put the patient for finer neuropsychological testing. That last thing wouldn't be strictly necessary, but I'm just going to the basic diagnostic tools. So the MMSE showed a mild cognitive impairment, and that could be sleep-related. It could be also vascular disease related. Does the patient have a vascular disease? We don't know. Let's see. Or Alzheimer's disease related. There are other reasons for that. It could be also pharmacological. There are many reasons. Okay, I'm going to show you what we did in order to investigate that. But first, the therapeutic strategy was A, improve RLS, because RLS is at this point creating the main obstacle to treat sleep apnea. Unless you treat the RLS, the patient was not able to use the CPAP machine because of the RLS. The RLS was he wouldn't feel comfortable at all with the RLS and the CPAP on top of it. So either you improve, either you unlock the RLS by treatment, or you won't be able to treat the sleep apnea, and you will have also the daytime sleepiness. Step number 2 would be, once this is achieved, treat the obstructive sleep apnea, and then reevaluate sleep again, and the EDS, the excessive daytime sleepiness. On top of that, in parallel, if you want, improve the cardiovascular function as much as you can, and reevaluate the cognitive function thereafter. Okay, what to do with the RLS? The first thing, what are the options for the RLS? First, change drugs. Well, problems. Patient is already on high doses of pramipexole, I said it before. And alternative dopamine agonists have already been tried. What other drugs do we have here? The alpha-2 delta ligands, like gabapentin or pregabalin, or even the latest one, the pyridamole, that works on adenosine. I don't think that in this kind of patient, these drugs are likely going to be effective, so we didn't even try them. Tramadol, okay, could be one of the options, or oxycodone, a mild opiate that it's approved for treatment-resistant RLS in Europe. The patient was here, so I know that there are, in other countries to obtain oxycodone might be difficult, but okay, I'm going to show you the way we treated, we solved the question here. We went for oxycodone at a dose of 5 milligrams per day. There is one problem. The patient is mildly hypoxemic. We normally look for, we measure arterial gases in order to see how high particularly the CO2 is. Because if the CO2 is high, you might reach, by administering a mild opiate, a further respiratory depression and complicate the whole thing. The approach would have had to be different. But in this case, it was not the case, so we got green light to go on with the oxycodone. That's something that Dr. Romero certified, and so I felt free to do it. Iron status. Yeah, as I mentioned, serum iron is marginally low. It's still okay, to be honest, but brain iron is low. So we have to make sure that the iron gets into the brain. So what do? We decided to administer ferric carboxymaltose, 1,000 milligrams administration, and see the effects. I'm not going to talk long about iron treatment. You will get a lecture, a specific lecture on how to do that in RLS patients, but just look at what we obtained at the first of all, the echogenicity index from being 0.15 jumped over 6 months later. It's a slow treatment, I know. It goes slowly up. There's no way to speed it up, but it went from 0.15 to 0.21, which is, whoa, it's already looking nice already at 0.21. It was a patient that absorbed the iron quite well. Ferritin jumped from 35 to 410. It's a little bit high, but no problem. That's exactly what we want. We want the patient to be mildly hyperferropenic for a few weeks or months. We do that together with a hematologist. It's a calculated risk. At the same time, the TSAT went from 21 to 29, fine, and what we ultimately wanted. The IRLS scale, which initially was at 31, severe RLS, fell down to 16 out of 40, which is already mild RLS. Together with the drugs, and later on, a few months later, with the iron, we were able to improve the condition significantly. Already with the drugs, after administration of oxycodone, we were able, the patient was sufficiently mild in terms of the RLS to be able to undergo a CPAP titration. And that's what you see. This is the report of the CPAP study. Again, like the previous study, we came to the conclusion that 8 centimeters were fine. And once the CPAP was administered and the patient was able to sleep longer, the ESS, this Epworth Sleepiness Scale, fell from 15 to 6. The patient, 6 is, anything under 10 is normal. 6 is a perfectly normal score. He was no longer somnolent during the day. What about the cognitive situation, now that the patient is no longer sleepy? Well, there you can see this is the result, and there is only one thing that is not right here. I mean, attention has improved significantly. Language has improved, but recall has not improved, pointing to a persistent, despite the CPAP and the improvement of nighttime sleep, this suggests that there is an ongoing memory problem and a so-called amnestic cognitive impairment. Which kind of cognitive dysfunction is caused by sleep deprivation? Sleep deprivation normally leads to impairments in alertness and in concentration. That's a typical thing for sleep deprivation, but also in executive functioning. With that, the patient becomes more difficult to focus and pay attention on things, becomes easily confused, etc. Also, sleep-deprived patients have difficulties in performing tasks that require logical reasoning and complex thoughts. The question here is, what kind of cognitive impairment does the patient have? It's not entirely sleep-related. It was partially sleep-related, but not all of it is sleep-related. So if you use neurologists know this quite well, and also internists know it well, the so-called modified Hachinsky ischemic score, you get a number of features and the score that you might give them. So we filled this out, and what we saw here, well, we gave fluctuating course, that was okay. A little bit of depression, yeah, he gets another score there. There was we were not available. We were not aware at the time that the patient had undergone. He was hypertense, but we were not aware of previous strokes. So I put that as a 0 with a question mark. So the total number is 5. Normally, anything under 4 suggests strongly Alzheimer's disease. Anything over 7 suggests strongly vascular dementia. Our patient has 5, so it's somewhere in between, in the gray zone. We performed an MRI, and we got 2 specific findings. One of them is the so-called degeneration of the white matter, leukoariosis, particularly periventricular, and also silent strokes. The patient had undergone strokes without silent, in the sense that these were not associated to any symptoms. And this kind of finding is highly suggestive of a hypertensive arteriopathy. It's also very common in patients undergoing diabetes. Our patient has diabetes, type 2, and smoking. Our patient was a smoker. So there is an element of vascular dependent cognitive impairment. Is that all? Well, I don't know, because when we looked at the hippocampus, we were able to see a mild atrophy of the hippocampus. The hippocampus is a structure, it's a brain structure that is very, very important in the connection of memories. An atrophy of the hippocampus means normally some problem in memory, and that points very directly to a potential Alzheimer's disease. How to know this? How to know this in this case? Well, first of all, let's look at just neurologically, the patient, the neurological examination was normal. There was no gait disturbance, no Parkinsonism, no behavioral abnormalities, no stepwise decline, just amnestic deficits. Out of the epidemiological studies show that most of the dementias, this is not a dementia yet, but it's a dementia in the making, in the process, are vascular. It's a mixture of vascular and Alzheimer's disease related. The second group is pure Alzheimer's disease, and the third group is pure vascular. The fourth group would be a mixture of Alzheimer's, vascular, and Lewy body disease. So the point I want to make here is that a mixture of vascular and Alzheimer's is quite a common thing. Okay, what happens? What's the relationship between sleep and Alzheimer's disease? Just to say it very briefly, neurons have proteins that cross the membrane and are called precursor. The name of the protein is the precursor protein beta amyloid. These are proteins that cross the membrane. The function is not very clear, but they seem to have a role in the intercommunication between neurons. Normally there is a process of cutting these long proteins in pieces by a kind of protein called secretase. One of the pieces emerging from that is the so-called beta amyloid. We all produce beta amyloid. That's part of physiology. However, the difference is that in Alzheimer's disease, these beta amyloids accumulates, sticks together, creates aggregates, insoluble aggregates, and at the end, these aggregates kill the neuron. It's as if you were not able to get your garbage at your home cleaned up every day, and at the end, the garbage is able to kill you. It might at some point. So it's something similar, oversimplifying it a little bit. Okay, what does it have to do with sleep? Yeah, if you look at the CSF in the cerebrospinal fluid, the CSF levels of beta amyloid, there is a kind of a circadian curve. And if the levels are maximal at the end of the day, yes, the longer you have been awake, the more garbage you have. Let's call it for now garbage, beta amyloid. During the night, during sleep, not during the night, during the sleep, there is a garbage collection system called the lymphatic system. It's a perivascular brain cleaning system that has the function, it's turned on during sleep, and it will recollect it. So that means during the night, the levels of beta amyloid, which is potentially toxic, decrease. And in fact, you can see on the right side that the longer, if you put someone under sleep deprivation, the longer the sleep deprivation, the less hours someone sleeps, the more beta amyloid accumulates in several areas, particularly in the hippocampus. So sleep is one of the mechanisms you have to defend yourself against the accumulation of the beta amyloid. Well, there are ways to measure it. How do you want to diagnose Alzheimer's? I know the diagnosis is a clinical one so far, but the degree of uncertainty, the problem right now is that by the end, the patient has all the symptoms, all the features of Alzheimer's disease, all the damage in the brain has been done already. There's little more to do. And that's one of the reasons why drugs are not effective. So it becomes crucial to be able to detect the accumulation of beta amyloid as soon as possible. And there are several techniques. These are expensive techniques. These are based on PET scan. These are, you have in many hospitals, this kind of, in some hospitals, these PET scans, but it's still expensive. It's not available for the common public. You can measure both beta amyloid and also very soon you will be able to measure tau, which is another protein that accumulates in the brain. A recent finding has shown that you can measure beta amyloid. There are two ways, by PET scan. The other one would be by measuring it in the cerebral spinal fluid by means of a lumbar puncture. Are you going to do a lumbar puncture on everyone that has memory problems on this patient? I would say no. However, you can draw blood, and by drawing blood, And if you measure beta amyloid in plasma, you will see that the levels are, and these levels are predictive for whatever is happening in the brain. Low levels of ratio of two different kind of beta amyloids, the 42 versus the 40, suggest that the same finding might be found in the brain, in the CSF. We did this, and we got a finding of 0.06. A finding of 0.06 is somewhere between the one you can see on the left-hand slide, it's the one between MCI and Alzheimer's disease. And for the tau protein, we found exactly the same thing. So the patient was highly suspicious of suffering from Alzheimer's disease as well. And this is my last slide. Knowing this, we decided. Okay, what about treatment? Okay, we can always try. This is a patient with mild cognitive impairment, with very mild one. Cholinesterase inhibitors have not been effective. You can always try them, but no trial has shown them to be very effective. The alternative is targeting, I'm really having trouble with the pointer, monoclonal antibodies. This is an emerging therapy. These are antibodies that will selectively locate the beta amyloid and interact with it and neutralize it and make it and be able to eliminate it. So the first of these drugs has been recently a year ago approved in the United States, is currently being examined in Europe. And there is another one that is currently under examination by the FDA. So it looks as if the future was going to look very similar to that. But there are other things that you can do on top of that. Treatment of vascular factors, we mentioned that. Since this is a vascular dependent memory impairment, try to treat it as aggressively as needed. The CPAP is absolutely a must. I just, I really feel ashamed for the lost time, for the many years of lost time that the patient had not received his CPAP. We might have been able to improve sleep by that, and by that not only to improve the quality of life of this patient, but also to improve, to slow down, possibly to slow down the progression of Alzheimer's disease. And this was my last slide, and I hope that you get the main message that sleep matters. It matters in many diseases. The number of diseases that are affected by sleep is important. And you, by learning sleep medicine, you might get a very different perspective, even of your own specialty. Of course, you might show interest in intrinsic sleep disorders, and also use them, get into that field and become one of our colleagues. So I welcome you to join our field, to join the master's degree first, and then to join our field. We will have this kind of seminars throughout the master's degree. So you will learn with us on specific cases. Thank you very much, and I will be happy to answer any questions if any of these arise.